Hi everyone, my name is Aiza Waheed and I'm a PGY6 in nephrology at UBC. I have an interest in CKD and today I'll be talking to you about CKD progression and management. I have about 5 parts to this talk, but if you have any questions, I'll be happy to answer them at the end of the talk. So with that, let's get started. I don't have any relevant disclosures. This is an outline of my talk for today. I'll start by going through the definition and prognostication of CKD. Then we'll talk a bit about the pathophysiology and natural history of CKD. Oops, sorry. We'll go through the general management of CKD patients as well as some of the complications that may arise. We'll talk about the management of comorbidities in CKD and some of the implications that CKD has in the management of these issues. And we'll discuss finally the medication management in chronic kidney disease. What is chronic kidney disease? Well, it's defined as abnormalities of kidney structure or function that are present for more than 3 months that have implications on overall health. Abnormalities of kidney structure that are indicative of kidney damage can be picked up using some tools like the urine ACR that can tell us that the kidneys are losing glomerular protein. Any urine sediment abnormalities like hematuria or white blood cells, some electrolyte abnormalities, or any structural abnormalities that are picked up on imaging, like polycystic kidney disease or a solitary kidney, etc., that would have implications on both your kidney function over time, as well as other potential comorbidities. I think we're all very familiar with decreased GFR as being an indicator of chronic kidney disease. And I want to make a point to just say that a GFR of less than 60 is abnormal. However, if you do have a GFR of greater than 60 and there is evidence of kidney damage indicated by proteinuria or abnormal urine sediment, then CKD is likely present as well. I'm going to spend a few minutes talking about GFR and what it means. Of course, it's how we measure kidney function. It's computed using the serum creatinine, and so it can't be interpreted when the creatinine levels are fluctuating. The creatinine has to be stable and steady state to get an accurate reading of the GFR. In patients with kidney disease and even normal kidney function, the GFR can fluctuate, and so it's very important to repeat blood work, including the GFR, to ensure or to diagnose CKD. And I just wanted to talk about how GFR equations were initially designed to follow individuals with kidney disease over time. And so at near normal values of greater than 60 mils per minute, GFR can actually be underestimated. And so it's harder to interpret fluctuations or changes in kidney function based on the GFR alone. For example, if the GFR was at 1.90 mils per minute and on repeat it was 80, it's a little bit difficult to tell if that really is a true difference in kidney function, because when the kidney function is normal, the GFR can really underestimate some of the numbers. So the creatinine may be a more useful tool to follow in that case. In BC, we use the CKD epi equation to calculate GFR, and it tends to be more accurate than normal kidney function. And lastly, GFR equations are also less accurate in elderly populations, so that's one of the caveats of these equations. This slide outlines some of the common and less common causes of chronic kidney disease. I think we're all familiar with diabetes and hypertension being some of the most common etiologies. Other vascular causes like renal artery stenosis, embolic phenomenon, etc., can contribute as well. Chronic prerenal injury that is often associated with end organ damage and heart failure or cirrhosis can lead to chronic kidney disease. And then other parts of the nephron, like the tubules, the interstitium, and the glomerulus, can have different disease processes that impact them, and that can lead to CKD as well. Some structural causes like obstructive uropathy or reflux nephropathy in children and young adults, or even autosomal dominant polycystic kidney disease are other causes of CKD, and the list goes on. It's important to identify the cause of chronic kidney disease because it has implications on the management of CKD, as well as the risk of progression depending on what the etiology is. And It also has implications on other complications that can arise. For example, people with polycystic kidney disease can have complications of liver cysts, heart disease, etc. I think you're all familiar with the screening guidelines for chronic kidney disease in BC. Typically, we screen people with diabetes, hypertension, cardiovascular disease, a family history of CKD, or individuals from high-risk ethnic groups for CKD, as well as a history of ACEi. I've added on a section on other, which includes nephrotoxic medications, malignancy, HIV, Hep B, Hep C, just because these processes can also have an impact on kidney function. So it's just to keep in mind that it's important to screen these individuals as well. And screening can happen with a serum creatinine, urinalysis, and urine ACR every 1 or 2 years. The staging and risk stratification for CKD includes these 3 points. Like we've already talked about, the cause of CKD is very important because it has implications on both the progression of kidney disease and overall health in individuals. The GFR category and the trajectory of CKD is also important because lower GFR has a risk of renal progression, but it also has other risks of mortality, cardiovascular disease, etc. Albuminuria is also important, and the degree of this is essential to know, and we'll discuss this a little bit more in a few minutes. But a lot of other factors contribute to the risk of CKD progression as well. So you can see here that age, sex, ethnicity, and hypertension and glycemic control, smoking, etc. are very important in understanding the overall risk of individuals who may progress to CKD. This is the heat map that I'm sure you're familiar with from the KDIGO guidelines. It illustrates the risk of progression based on GFR as well as proteinuria. And you can see I don't think you can see my cursor here, but the proteinuria cutoffs have been indicated in the A1, A2, and A3 sections. And an ACR of less than 3 is essentially normal, but with different gradations, the risk of CKD progression goes up. I've created some examples of 3 individuals here with the same GFR, but different levels of proteinuria and slightly different clinical pictures. And I'll give you a minute just to take a look at them and think about their risk of progression to end-stage renal disease. Who do you think has the highest risk, and what do you think the risk is? We'll come back to them in a few minutes. So the first patient is an 86-year-old with CKD from hypertension with a GFR of 30 and an ACR of 1. A 72-year-old with CKD from diabetes and hypertension with a GFR of 30 and an ACR of 70, and a 48-year-old with CKD from diabetes with a GFR of 30 and an ACR of 400. So we'll come back to these in a couple of minutes once we talk more about proteinuria. So albuminuria represents glomerular protein loss in CKD, and it's associated with CKD progression and other renal and cardiovascular outcomes. Typically, we excrete less than 30 milligrams of albumin in a day, but in CKD, this can be far greater, especially depending on the cause of CKD, such as in diabetes or IgA nephropathy. The urine's dipstick is very specific for albumin, but it is quite insensitive, especially at lower levels of albuminuria. And so we estimate that individuals may be losing close to 300 milligrams of urine albumin a day before the dipstick picks it up, which is quite different from what the normal urine albumin excretion is. So we like to use the urine ACR on a spot urine to get an estimate of the proteinuria. A urine ACR of 2 is normal, so 2 or less is normal, and it equates to about 20 milligrams of urine protein in a day. I will say that if you note an abnormal urine ACR, you should repeat it once or twice to rule out any evidence of transient proteinuria. And transient proteinuria is common and can happen in episodes or at times of significant elevation in blood pressure, strenuous exercise, fevers, urinary tract infections, etc. So it's not necessarily indicative of glomerular protein loss. There are some other causes for it, which is why it should be repeated. This is a figure that shows the relationship of GFR and albuminuria to overall mortality, cardiovascular outcomes, as well as kidney outcomes of end-stage renal disease, AKI, and progressive CKD. So you can see that at lower GFRs below 60, and certainly at GFRs below 30, the risk for all of these outcomes goes up. And if you look at the different proteinuria cutoffs as well, with every gradation of increase in proteinuria, the risk is also higher. So how do we calculate the risk of progression in people with CKD? Well, in nephrology, we use tools such as the kidney failure risk equation to help give us this risk. And this equation incorporates the age, sex, region, which is typically North America for us, GFR, and urine ACRs to give us an answer, or a percentage over 2 years or 5 years. So I'll go back to our cases here of our 3 patients, and I've applied the KFRE to each of these individuals. So the 86-year-old woman with a GFR of 30 and an ACR of 1 has a 0.8% 2-year risk of end-stage renal disease and a 2.5% 5-year risk of end-stage renal disease. The 72-year-old male with CKD from diabetes and hypertension with a GFR of 30 and an ACR of 70 has a 9% 2-year risk of end-stage renal disease and a 25.9% risk of end-stage renal disease at 5 years. And the final patient, our 48-year-old with a GFR of 30 and urine ACR of 400, has a much higher risk of 30% progression at 2 years and 67% progression at 5 years, which is largely driven from his very high ACR of 400. So this just illustrates for you how proteinuria is quite a significant marker of progression of chronic kidney disease. So now that we've discussed some of the prognostic markers, I'm returning to the heat map here, and this time showing some of the thresholds for referral and also some of the thresholds at which you'd be more inclined to refer sooner. So with decreasing GFR and increasing ACR, patients should be seen sooner by nephrologists, and they're triage as such as well. But I will ask you to keep in mind that these risk equations and the heat map don't really take into consideration the prior trajectory of GFR decline in patients or other risk factors such as the cause of chronic kidney disease. So there is a caveat to this. Okay, so now we'll move on to the pathophysiology and natural history of chronic kidney disease. The course can be very variable for patients with chronic kidney disease. Most of them may retain their GFR over time and not progress to end-stage renal disease. In fact, most patients with chronic kidney disease die before needing dialysis or transplant from other causes like cardiovascular disease. Chronic kidney disease is a risk factor for CV disease, and so that's why a lot of our studies look at cardiovascular outcomes. Patients with CKD may progress to end-stage renal disease, and the usual rate of progression is 1 to 2 mils per minute of GFR loss per year, and rapid progressors are defined as patients who lose more than 5 mils per minute of GFR per year. But CKD patients can also have acute kidney injuries, which we describe as acute on chronic kidney injuries. And these are associated with progression of CKD as well. So after an AKI, CKD patients may return to their previous GFR, or they may have some decline, or they may decline at a more rapid pace. I've already touched on this, but CKD progression depends on the etiology as well. So people with mild IgA may have asymptomatic hematuria alone or some mild protein, or may progress to end-stage renal disease. Patients with diabetes can develop proteinuria and then have eventual progression to end-stage renal disease. Other individuals can have repeated sustained insults to the kidney that leads to fibrosis and scarring. And some hemodynamic mechanisms can also contribute, such as the use of diuretics, RAS inhibition, etc. Many causes of CKD have hyperfiltration as a compensation. So when kidneys have some injury to them, their response is to compensate an increased filtration rate in the healthy leftover nephrons. And this is called hyperfiltration. This mechanism maintains normal kidney function over time. And this phenomenon usually happens in patients with diabetes, obesity, low renal mass, like in a solitary kidney, polycystic kidney disease, and some other glomerular diseases. But over time, the hyperfiltration also results in long-term damage to the glomeruli in the remaining nephrons, and this results in proteinuria and progressive renal failure. So that's why we aim to prevent this process with ACE inhibition or ARBs, and we've shown that this can slow the progression of chronic kidney disease and also preserve kidney function. So I mentioned that patients with CKD can have acute kidney injuries. In fact, they're at risk of acute kidney injuries. And again, AKI can increase the risk of chronic kidney disease progression, as well as end-stage renal disease and death. And so it's very important to prevent and treat AKIs. But remember that baseline GFR fluctuations are very common in patients with CKD. And so it's important to use the creatinine when the kidney function is fluctuating, because the creatinine needs to be in steady state before the GFR can be accurately read. And it's also important to repeat the labs to identify an acute kidney injury. AKI in kidney disease can happen for a number of reasons. In fact, it can happen for reasons very similar to individuals who don't have kidney disease. If you suspect an obstruction, especially in people with a history of abdominal surgery or malignancy, or older males with lower urinary tract symptoms, I would suggest getting an ultrasound as soon as possible. Volume is a very important factor in determining what you should do with people with an AKI. And so if you feel that they're volume deplete, a trial of fluid would be helpful. Or if you find that they're volume overloaded or have cardiorenal syndrome, then a trial of diuretics. It's always important to ask about nephrotoxic medications and discontinue them if they're present. And to also perform a urinalysis to make sure that there's no evidence of any activity in the glomerulus, like hematuria or increased proteinuria. It's important to quantify the proteinuria with urine ACRs, and also to look at complications of AKIs. We often get asked about what to do with ACEs and ARBs in an acute kidney injury. So during times of acute kidney injury, it is important to avoid further injury to the kidney and the nephron by holding medications that have hemodynamic effects. And some of these include ACEs and ARBs, as well as Entresto, and diuretics. Unless, of course, somebody is very overloaded with volume and needs some diuretics on board. Once medications have been held and all of the reversible causes have been assessed, it's important to repeat the labs to reassess the kidney function. And again, it's important to avoid initiating or increasing doses of ACEs and ARBs during times of fluctuating kidney function. So I'll move on to the next section, which is management goals in CKD. So our goals are to identify and manage reversible causes of CKD, to slow the progression of renal disease and GFR loss, to treat the complications of chronic kidney disease and other comorbidities that may arise, and to keep a close eye on medications and adjust the doses for the level of GFR. In the kidney clinic, our role is to also prepare patients for renal replacement therapy, if and when appropriate. Good blood pressure control has been shown to control the rate of CKD progression. And recently there have been a number of studies that have been published in blood pressure management, and so the blood pressure targets are constantly changing based on new data and new guidelines. But in general, our target blood pressure is less than 140 or over 90 in most individuals. In individuals with diabetes, the blood pressure target is less than 130 over 80. And as nephrologists, if there's evidence of proteinuria, then we target a blood pressure of less than 130 over 80 as well, in some cases. Individuals with polycystic kidney disease who are under the age of 50 and have relatively preserved GFR were a bit more aggressive for targeting blood pressure less than 110 over 75, as tolerated. And since the Sprint publication a few years ago, this study included individuals who were over 50 and had cardiovascular risk for an intermediate cardiovascular risk, and about a third of them had CKD, and it showed that blood pressure targets of less than 120 or closer to this had an improvement in CV outcomes. So this target would be mainly for reduced cardiovascular outcomes rather than CKD specific outcomes like progression or proteinuria, but it's something to keep in mind. ACEs and ARBs are very useful medications in kidney disease. They reduce intraglomerular pressure and glomerular hypertrophy that would result in damage over time. They reduce albuminuria, which is correlated with slower progression of CKD. And it's also necessary to have a low sodium diet when these medications are on board to further enhance the antiproteinuric effect of these agents. So overall, they reduce the progression of chronic kidney disease and end-stage renal disease, and they're very important in kidney and cardiovascular health. The best evidence for ACEs and ARBs is for proteinuric chronic kidney disease, but they're often prescribed in non-proteinuric CKD for other indications like heart failure with reduced ejection fraction, patients with diabetes, hypertension, etc. In nephrology, we continue these medications in all levels of GFR in CKD patients who are progressing for an overall cardiovascular protective outcomes. But in advanced CKD, when patients may start to develop increasing potassiums, we're pretty cautious in stopping them if we're finding that the potassiums are going up. Anytime you start an ACE or ARB or adjust the dose, it's essential to check the creatinine and electrolytes 1 or 2 weeks after. Especially after starting an ACE or ARB, we may accept up to a 30% increase in creatinine, but this is all dependent on, you know, if the renal function continues to improve or worsen. And there is a risk of acute kidney injury with these medications. So on the long term, they're very beneficial and useful for kidney outcomes and cardiovascular outcomes. But on the short term, when renal perfusion is low, like in the setting of volume depletion or heart failure, it's important to hold some of these medications so that they don't contribute to an acute kidney injury. In CKD, I've created a little bit of an algorithm for hypertension management here. So in CKD, ACEs and ARBs can be used as first line for patients with proteinuria, diabetes, or heart failure. Diuretics are very useful as add-on therapy because hypertension in CKD is often associated with volume overload. Calcium channel blockers can be added to the ACEs and ARBs in diabetes. We don't combine ACEs and ARBs because there's a risk of hyperkalemia and worsening renal function. And bedtime dosing of antihypertensives can restore nocturnal dips in blood pressure, which also would reduce the cardiovascular risk. And finally, sodium restriction is very important in blood pressure control, especially in CKD, because individuals lose their ability to excrete salt, and so both diuretics and sodium reduction is helpful in this sense. I'll speak a little bit about diabetes now. So our hemoglobin A1C target in CKD population is the same as the general population at 7%. In older individuals, we target a higher hemoglobin A1C. One thing to keep in mind is that the A1C can be artificially lower in CKD, especially advanced CKD, as red cells have a shorter RBC lifespan. And so people with advanced CKD may have more impaired diabetes control than the numbers would suggest. However, we still target the same hemoglobin A1C levels as the general population. I'll spend a few minutes talking about metformin now. So metformin is a very useful medication in diabetes, especially in patients with CKD and diabetes. However, it can accumulate in renal impairment. It's not a nephrotoxic medication in that it doesn't do damage to the kidneys. In fact, it can be protective. But in patients with impaired renal function and lower GFRs who have accumulation of metformin, it can result in a profound lactic acidosis. And a few times a year, we do end up having to dialyze patients who have stayed on their metformin and were on their RAS inhibition during a time period when they were feeling quite unwell, like having nausea, vomiting, diarrhea, and became quite volume deplete, and developed an acute kidney injury and then a profound lactic acidosis. And so it's important to focus on sick day medication management with metformin as well. The doses need to be adjusted at lower GFRs. So we dose reduce to about half the usual dose at GFRs is less than 45. And we typically stop if the GFR is less than 30. And some nephrologists may keep it on at a reduced dose until about a GFR of 25 or so. But again, it's very important to hold it during periods of AKI and even during contrast exposure that could potentially give people an AKI to reduce the risk of the profound lactic acidosis. As renal function progresses, there are some other agents that could be used in place of metformin and other contraindications in advanced CKD. So glycoside, linagliptin, and insulin are safer choices in advanced CKD and end-stage renal disease. Insulin half-life increases with declining renal function, and so it often requires a dose adjustment. Diabetic nephropathy is a very common cause of chronic kidney disease and end-stage renal disease. And we know that blood pressure control and glycemic control are very important in preventing progression in these individuals. ACEs and ARBs, about 15 years ago or so, were shown to be of benefit in proteinuria reduction and GFR preservation. And so they're very important in patients with diabetes to be on these medications, especially if they have evidence of proteinuria. More recently, though, SGLT2 inhibitors are being brought into diabetes management, and there's evidence for cardiovascular benefit in patients with type 2 diabetes with the initiation of SGLT2 inhibitors. And more recently, in the last year, SGLT2 inhibitors have been shown to have renoprotective effects as well, independent of the glucose lowering. So the CREDENCE trial, published about a year ago, showed reduced risk of end-stage renal disease and CKD progression with SGLT2 inhibitors when they were added onto RAS inhibition. And so they're indicated in GFRs greater than 30 mils per minute and proteinuric CKD in patients with diabetes who are already on maximally tolerated RAS inhibition. And once again, it's important to remember to hold ACE, ARB, SGLT2, metformin, etc. during parts of ACEi and as part of the 6-day medication management plan. So now I'll move on to talking a bit about the complications of CKD. Hyperkalemia can happen with advanced chronic kidney disease, and we treat this with a low potassium diet. And if the potassium stays above 5.5, we add a low dose of a binder a few times a week. Diuretics can also help lower potassium. And in advanced stages of CKD, if ACEs or ARBs are still on board for hypertension alone, like no diabetes, proteinuria, heart failure, etc., you can consider discontinuing them if having trouble with hyperkalemia. As kidney function declines, there's a reduced ability to excrete acids, and so metabolic acidosis can occur. Metabolic acidosis has an association with progression of kidney function decline, and bicarbonate supplementation has actually been shown to slow the progression of CKD. And so we start sodium bicarbonate tablets at bicarb levels of less than 22 to maintain a bicarb level in the normal range. Mineral metabolism and bone health are also affected by chronic kidney disease. I have a little diagram here of how the calcium, phosphate, PTH, and vitamin D axis works, but the main defects are that vitamin D is not activated in advanced CKD, and there's also an inability to excrete phosphate. And clinically, we see low calcium, high phosphate, and high PTH. There is a theoretical risk in advanced kidney disease of calcium phosphate precipitation, especially in the vasculature. And so we try to maintain near normal levels of calcium and phosphate to avoid this. Hyperphosphatemia has been associated with end-stage renal disease and cardiovascular mortality, but it hasn't been shown that improving phosphate actually improves these outcomes, but we still try to treat it to near normal levels. So the management of mineral metabolism is to first limit phosphate-rich food. If there is hyperphosphatemia, we start binders, initially calcium-based to help replete some of the calcium, and then non-calcium-based. Vitamin D can be added if the PTH is a little bit high, but nephrologists may add 1-alpha-calcidol if the PTH goes higher, especially in more advanced CKD. And the targets for therapy are normal or near normal phosphate and calcium levels. The PTH target really varies with the GFR stage, and certainly at early stages of CKD, we don't really follow PTH, but it's when you get to the stage 5 and dialysis patients that we target a PTH that's 2 to 9 times the upper limit of normal, and this is to make sure that it's not too low to prevent adynamic bone disease and not too high to prevent renal osteodystrophy. Bone health can be challenging to manage in CKD, partially because our patients tend to have a lot of risk factors for fractures, but the treatments are also limited. Bone mineral density testing is not always reliable in advanced CKD, and although the bone biopsy is gold standard, it's rarely performed. Very high and very low levels of PTH are indicators of bone turnover, and so that's why we target this range of 2 to 9 times the upper limit of normal in more advanced CKD. And the management of osteoporosis is quite challenging. Bisphosphonates can be limited by the GFR, and they have to be used with caution. And denosumab or Prolia can cause severe hypocalcemia, especially in patients with advanced CKD and dialysis. And we do see this often, that people can have quite profound and severe hypocalcemia for quite a long period of time once they get Prolia. So we do try to avoid it in advanced CKD and dialysis patients. Anemia is also common in CKD, and we usually see this as a complication of CKD at GFRs closer to 20. We investigate it with iron studies and rule out other causes like B12 deficiency. CKD patients tend to be iron deplete because of GI losses, and so the treatment starts with ensuring that patients are iron replete. And once replete, an ESA, so EPO, can be considered if there's ongoing anemia with low GFR and hemoglobins of 90 to 100. I will say that studies have shown that attempting to correct anemia to normal hemoglobin levels hasn't been shown to benefit individuals with CKD, and comes with a risk of higher risk of strokes. And because of that, the target hemoglobin for patients who are treated with EPO for anemia is a hemoglobin of 95 to 115. So we'll move on to the management of comorbidities in CKD. Cardiovascular disease is very common, and in fact, CKD is a risk factor for cardiovascular mortality. Cardiovascular mortality is the most common cause of death in CKD patients, even more common than needing dialysis. The management is that of managing the risk factors, which you're all familiar with. And a point to make here is that the BNP and troponin are cleared by the kidney, and so these tests can be difficult to interpret in the setting of impaired GFR, and so you can follow the trends rather than the absolute values in many cases. But they're quite challenging to interpret. The management of lipids in CKD is like the usual guidelines. So I've put a slide from the Canadian Cardiovascular Society guidelines below, and they indicate that individuals with CKD who are over the age of 50 should be on a statin. And this again is because of cardiovascular benefit, as CKD is a risk factor for CV outcomes. Statins have not been shown to improve kidney function or slow down the progression of CKD, so this would be solely for a cardiovascular outcome perspective. Heart failure, especially with reduced ejection fraction or preserved ejection fraction, are very common in CKD. Heart failure with reduced ejection fraction is usually treated with ACEs and ARBs, or ACEs or ARBs, beta blockers and MRAs. And these medications can increase the risk of hyperkalemia in CKD, so it's very important to follow the electrolytes closely. Important to follow the kidney function, especially after initiation of ACEs, ARBs, and spironolactone, as well as dose changes and at times of volume depletion to ensure that the kidney function is stable and that there's no risk of hyperkalemia. For individuals who can't tolerate ACEs or ARBs because of kidney impairment or hyperkalemia, they may need to be switched to a combination of nitrates and hydralazine, which have been shown to be of benefit in these populations. And just a side note, Entresto is becoming increasingly common in the management of heart failure, and it is a combination of valsartan, which is an ARB, and a neprilysin inhibitor, which has diuretic properties. And so it should be treated like an ACE and an ARB in the sense that anytime there's an initiation or dose increase, the electrolytes and kidney function should be checked closely, and individuals should be given guidance on sick day medication management with this class of medications. Volume overload is common in CKD as well. We treat this with diuretics, especially loop diuretics. Now, loop diuretics need to be given at higher doses in patients with lower GFR as they have to be excreted into the tubules. Adjunct medications like metolazone can be added, but these have to be used in caution to ensure that people are not hyponatremic or before or after they start these medications, because they are thiazide-like diuretics. In significant volume overload states, we may need to switch to IV diuresis because of gut edema. And as part of all heart failure and volume overload management, there needs to be a focus on sodium and fluid restriction and following daily weights to ensure that patients aren't gaining fluid volume. The kidneys excrete uric acid, and so it can start to accumulate in CKD. It's really unclear if hyperuricemia contributes to the progression of CKD, and some observational studies are quite contradictory. And it's also unclear if treating asymptomatic hyperuricemia in patients who don't have gout with urate-lowering therapies slows down the progression of CKD. But in any case, if individuals are on allopurinol and febuxostat, their dose needs to be adjusted in CKD. Gout is also very common in CKD and can be quite challenging to manage because NSAIDs are contraindicated in this group. For prevention of flares, we can initiate allopurinol in individuals with CKD sometimes after the first flare because they're at higher risk of getting flares. And we start low and go slow with the initiation. So we can start at a dose of 50 milligrams and slowly up titrate it to target uric acid levels. And there is caution that has to be used with allopurinol, as people with the B5801 allele are at risk of hypersensitivity reactions with allopurinol. So we often in the CKD clinic screen them for this if they come from high-risk ethnic groups. Febuxostat can be used in individuals for gout prevention, but usually is reserved for people with GFRs more than 30. And we maintain some anti-inflammatory on board with initiation of the preventative medication, so either prednisone or colchicine for a few months so that we prevent flare formation once we start them on these medications. In terms of the anti-inflammatory agents that are available for acute flares, of course, we avoid NSAIDs in people with low GFR. Prednisone is an option at a low dose for a short period of time, and many people have relief of this, although some people may not tolerate prednisone for diabetes, etc. Colchicine may also be used and is typically most effective when started at the onset of symptoms, but there's a lot of caution that has to be used in terms of dose adjusting it for the GFR. And finally, dietary and lifestyle factors are helpful in the management of gout as well, but people often need pharmacotherapy for it. This is a table from a paper published in 2017 in AJKD, just giving guidelines on some of the agents that can be used in CKD for gout flares. And so you can see that it's mainly colchicine and glucocorticoids, and that colchicine has to be dose adjusted in CKD, especially in advanced CKD and dialysis, to prevent adverse events. So I'll finish the talk now talking about medication management in CKD. Many medications are indicated in CKD, like ACEs, ARBs, SGLT2 inhibitors, etc. Certain medications are nephrotoxic in that they can cause damage to the kidney, and these include NSAIDs and aminoglycosides. And other medications are metabolized by the kidney and may accumulate in renal failure, and this includes medications like NOACs, metformin, etc. It's also very important, like I've mentioned a few times, to discuss sick day medication management with patients, and I'll touch on this a little later as well. So NSAIDs are antiprostaglandins that cause afferent arterial vasoconstriction, so they reduce the perfusion to the kidney, and that's why we avoid their use in GFRs of less than 60 or proteinuria, so patients with CKD. If individuals are on other medications that have hemodynamic effects like ACEs, ARBs, or diuretics, and are prone to AKIs, we advise them to hold these medications if there is a decision made to use NSAIDs. And NSAIDs should only be used very sparingly for very short periods of time. But my recommendation is to avoid them altogether if possible. I've listed a few alternatives to NSAIDs. In gout, again, we use dose-adjusted colchicine or prednisone and add allopurinol for prevention of flares. For other types of pain, Tylenol, Tramadol, topical Voltaren may be considered. For neuropathic pain, low-dose gabapentin is an option. And if you're choosing an opioid or an opiate, hydromorphone is preferred over morphine. CT contrast is also considered a nephrotoxin. In itself, it doesn't cause damage, but when there are other factors involved, like other hemodynamically active medications or volume overload or volume depletion, contrast can cause kidney dysfunction because it has both hemodynamic impacts and it's also toxic to the tubules in the medulla. So anytime contrast is given, we advise holding ACEs or ARBs, diuretics, and metformin the day before the test, to repeat the blood work a few days after the procedure and the contrast exposure, and to restart the medications when the GFR is confirmed to be stable or at baseline. This is a list of some common medications that need dose adjustments in CKD. It includes allopurinol, which we slowly titrate to target uric acid levels, as well as colchicine, but also gabapentin, metformin, bisphosphonates, a number of antibiotics, antivirals, and of course the NOACs and DOACs, which are used very frequently for patients with anticoagulation needs, especially in the setting of AFib, but should be used with caution in lower GFRs. And I believe the GFR cutoff currently, or the creatinine clearance cutoff rather, is 25 mils per minute for NOACs and DOACs at this time. And finally, sick day medication management is the last thing I'll talk about. If individuals are ever on this combination or any of these medications, it's very important to discuss with them that if they're ever suffering from an illness that's causing severe dehydration, for example, a febrile illness, significant nausea, vomiting, diarrhea, etc., they should be instructed to hold this list of medications and any other medications that can cause hemodynamic effects in the kidney. So ACEs, ARBs, which includes Entresto, diuretics, metformin, NSAIDs, SGLT2 inhibitors, etc. And this is to prevent acute kidney injury and its complications, as well as lactic acidosis from metformin. So that concludes my talk. And in summary, chronic kidney disease is a common syndrome with many etiologies and varying rates of progression. There are targeted therapies at this time for the management of, there are targeted therapies for CKD, and they include hypertension management, diabetes control, ACEs and ARBs for proteinuric CKD, and SGLT2 inhibitors in patients with diabetes and proteinuric CKD. CKD is associated with complex comorbidities and can impact their management based on the GFR levels. Many medications are indicated in CKD, but they may have to be dose adjusted, and some are nephrotoxics and to be avoided. And finally, sick day medication management and education is important to prevent adverse effects of many common medications. So I'll stop for questions at this point.
Hi all, if you do want to say your questions verbally, you can just click one of the little icons at the bottom, like with a thumbs up or something, and then I can unmute you so that you can ask your question if it's verbal. And it looks like there is a question in the chat box.
So the question is, are you aware of any evidence to start an antihypertensive at bedtime slowly for non-dipping found on 24-hour ambulatory blood pressure monitoring, even if not hypertensive at bedtime? From Hillary Wu. So hello, Hillary. Thank you for your question. I can't, off the top of my head, I can't think of the specific evidence, but I think I have come across a paper that's shown that it can prevent cardiovascular outcomes to dose medications at bedtime, but I'm not sure if that was for non-dipping blood pressure. I will have to look into that. Thank you for your question. But I do know that non-dipping at overnight is associated with cardiovascular outcomes. And so that's one of the reasons we think about dosing medications at that time.
Just to answer Julie's question while she's still on here, the video of this will be posted, and it's up to Dr. Waheed if she'd like to have also the presentation posted additionally.
Sure, I can send you my slides.
Okay, perfect, thank you. Were there any other questions coming in? There we go. Looks like there's another one from Hillary.
That's a really good question. So do you have recommendations for how to diagnose osteoporosis given the limitations of bone mineral density testing? Well, I think the newer guidelines actually suggest that it can be useful in terms of diagnosing osteoporosis or osteopenia in patients with CKD and even advanced CKD. The only challenge is that these patients can be quite difficult to manage in terms of the medications options that are available. And so it would be risk factor reduction, like vitamin D, calcium, etc. But there isn't any diagnostic technology that I'm familiar with to help diagnose osteoporosis in this population. There is bone biopsy, but that's very limited in terms of where it can be done and how it's interpreted, and so it's not routinely offered to patients for a diagnosis.
Okay, well, it doesn't look like there's any other questions coming in. If there are, you can always email them to me and I can pass them on, me being Sidoni, the organizer. And these will be posted shortly. I'll be sending out the post-event survey in the next hour, and certificates go out in a week once surveys are done. So thank you everyone for attending, and we hope these will be a bit more regular going forward.
Thank you very much.